Thank you. Thank you so much for having me in Texas. It's nice to get out of Indiana. I'll be very honest with you. The talk I planned to give to you a week ago is very, very different than the talk that I get to do. I don't have like canned slides, so I do write a talk every single time, but I was mostly done by last week, and Tuesday upset that greatly. So we'll talk about it 2017 and beyond, but it is a much different world today than it looked like just a week ago. When I was a medical student, I was taught a class by a guy named William Kissick, who was one of the original designers of Medicare. And he gave a class called Healthcare Economics. And participation and just showing up in class was all you needed to do to pass. And so very few people paid attention, but there's one thing that I got out of it. And it was what many people refer to as the iron triangle of healthcare. He talked about the fact that all healthcare systems and all healthcare reform has to be thought of in three domains. How much does it cost? How do people access it? And what kind of quality does it deliver? What makes it an iron triangle is that you can really only get one or maybe two of these things, but it has to be at the expense of the third. Healthcare reform and healthcare systems are about trade-off. I can make a system that is cheaper, but either it won't have as wide access or it probably won't be as good. I can make a healthcare system that has universal access tomorrow, but either that will cost money or again, quality is likely to suffer. And I can commit to having the best healthcare system in the world, bar none, but again, that's likely to be expensive, or it's likely to mean that access will have to be constrained in some way. And then promising people that you will improve access, that you will improve quality, and that you will reduce spending all at the same time really doesn't happen. That it's almost impossible to do. It is what politicians promise us all the time. But healthcare reform is about trade-offs. Rational healthcare systems try to maximize one or two of these, recognizing that they can't get all of them. But they'll at least commit to trying to do something very well. And that's sometimes where the United States can fall short. Let's talk about access first. This is what healthcare reform has been fought about for the last few decades. You're looking at the percent of the population covered by the 31 countries in the Organization of Economic Cooperation and Development. It is not important to be able to see most of them. They're almost all bunched up at the top there. Because almost every other country in the world, whether it be a private system, a public system, some hybrid, almost all of them manage to provide universal health care in some ways, or universal coverage in some ways, to their citizens. The three that don't are the United States, which is that bright red line across and horizontally there, and then Chile, Turkey, and Mexico, one of which seemed to have been making a run for us in the last couple of years. But the United States for decades had a pretty stable percentage of its population that was uninsured. This was intolerable to many people in the country, and they wanted to fix it. And it was about reducing uninsurance. And that's how we got to the Affordable Care Act. And if there's any group that probably understands it already, it's you, but just to remind everyone, it has three principles. The first is that everyone should be able to get coverage even if they're sick, and they shouldn't be charged more if they are sick. It's the guaranteed issue in the community ratings. The second is if we do that, if we force insurance companies to give policies to people and we tell them they can't charge more than they're sick, there's a natural instinct. There's no moral judgment. It is simple economic sense that people should not buy care when they are well. They should wait until they're sick to buy care because they can't be denied a policy and they can't be charged more. That results in a gaming of the system and eventually a death spiral. So to make sure that doesn't happen, we have to make sure that everybody can afford the insurance plans so that if we make them buy them, they'll be able to buy them. And those, of course, form the regulations, the individual mandate, and then the subsidies, which are the three-legged stool of the Affordable Care Act. It's a three-legged stool because if we pull out any one of them, it falls apart. If we don't have an individual mandate, then only sick people will buy insurance and will enter a death spiral. If we don't have subsidies, then even if we have a mandate, everybody will be exempt from it because almost no one will be able to afford the insurance, even at community ratings, and we wind up in the same problem. And of course, if we don't have the community ratings and the guaranteed issue, the whole thing wasn't really worth it to begin with. So for a long time, people have argued that this is the only way to hold this together, that this is how the Affordable Care Act works, and that pulling out any one pillar will reduce it to nothing. And on the metric, this metric, it appears to be succeeding. What you're looking at in the yellow bars there is the percentage of the population that was likely to be uninsured without the Affordable Care Act. And if you look at the green bars, it's the percent of the population that is wound up being basically insured by the Affordable Care Act. About 20 million plus people have picked up insurance either through the exchanges or through the Medicaid expansion. On this metric, fine, the Affordable Care Act has been has been succeeding. But there are many other metrics of access which matter other than insurance, and on those, the United States often does not do as well. What you're looking at here is the percent of people who are unable to get a same-day appointment when sick in the United States and in a number of other developed countries. You should note that we beat Canada. That will be a common theme here. We often beat Canada. There's a reason that politicians reach into that bucket whenever they want to demonize another country and talk about how great we are. We beat Canada. But there's lots of other developed nations in the world, and when it comes to getting a same-day appointment when sick, the United States does worse than almost all of them. It is very difficult for people in the United States to get the care they need, even when they have insurance, at the time that they want it. You're looking here at the percent of people who have difficulty getting care on nights, weekends, or holidays. Again, we beat Canada and one or two other countries, but most countries beat us. It is hard in the United States to get care after hours. That's a real problem because a significant amount of life occurs on nights, weekends, and holidays. It's an even bigger problem because those are the times people don't work. And if we ask parents to take their kids and take them out of school, that can hurt them at their job. Taking time off for themselves can hurt them at their job. And when jobs are tight and economy's been problematic, it is getting harder and harder for people to get off them. This is actually one of the main drivers why we see more emergency room care in the United States than other countries. That's where it's open when people can go get care. People go to the emergency room not because they don't have insurance. In fact, as we've seen as the Medicaid expansion has increased insurance, more people have gone to the emergency room. Not because they were uninsured and didn't go. That's when they can get care. And that is often when the access is available to them when they are sick, again, remembering it's very hard to get a same-day appointment, and when they might not be working. But the biggest access problem of all is cost. What you're looking at here is the percent of people who report that they do not get a lab test that's been ordered for them, do not fill a prescription that's been given to them, and do not go to a referral to which they've been sent because of the cost, the out-of-pocket cost. About a third of American citizens, if not more, avoid care because of cost, which means that more people do that in the United States as well than any other country in the world. It gets a little bit worse. The data's a little older because the health affairs study that sort of does this every few years stopped doing it by income. But this is 2010 data. This is that same slide, but I've broken it out between the richer half in yellow and the poorer half in green. This again is the percent of people who report avoiding care because of cost. What I want you to note is that the richer half of America, yellow, is more likely to avoid care because of cost than the poorer half of almost any other developed nation in the world. And also recognize that the richer half of America is very, very likely to be insured. So even when insured, even when wealthy, more people avoid care because of cost still in the United States than in almost any other country we compare ourselves to. So while access has been improving, I would still argue that it is far from optimal. And so therefore access has not been what the United States has been pushing as the thing that we do well. Let's talk about cost. What you're looking at here is a complicated budgetary document, but this is how the CBO, or the Congressional Budget Office, looks at the long-term fiscal outlook for the United States. The shaded areas are spending. The dotted line that runs horizontal is revenue. The very few times that the dotted line is above the shading, the United States is in a surplus. You can see a very small period of time around the late 90s into 2000 when that was occurring. We were in a surplus. Anytime the dotted line is inside the shading, the United States is at a deficit, and this deficit is defined as a percentage of GDP. Non-interest spending, things that we talk about as spending, the things that often politicians want to cut, is the bottom thing there. You can see that it's spiked with the stimulus, and then it's been coming down gradually, and you can see projecting the future, it's getting better and better. While we talk about cutting non-interest spending in the future, discretionary spending, if you will, it's not sort of the major driver of future costs. Neither is Social Security, which is that dark blue band in the middle. You can see that it drifts upwards as the baby boomers are retiring, and then it starts to come back down. Social Security is a problem. It's a fixable problem. It's a problem that you can see there. It's like you can imagine with a tweak or two, we could probably get a handle on Social Security. The top portion there is healthcare spending. It's Medicaid, Medicare, CHIP, and the exchange subsidies. And don't be fooled. That went up and got bigger with the Affordable Care Act to some extent because, of course, we increased Medicaid spending. We increased spending in the exchanges. We don't have a spending problem in the United States. We have a healthcare problem. Healthcare, by far, is what's going to drive us into a ditch fiscally in the future. We can talk about cutting spending, we can talk about Social Security, but that is what's going to get us. That's the projection that seems to be where everything is going to get swallowed. It's not just a public problem either. You're looking at 4 lines. This is all employer-sponsored private health insurance. The light gray line at the bottom there is inflation, which has been pretty low over the last decade or so. Just above inflation has been worker wages. So they've been growing together slowly, much more slowly than we'd like to see. The top lines there, one of them is the premiums for employer-sponsored health insurance, and the other is employee contributions to premiums for health insurance. One of the reasons wages have been so flat is because we have to keep dumping whatever money we might put into raises into those increasing costs. Not just the employee side, but the employer side as well. And economists will tell you employees are paying for both of it. You know, in the end of the day, whether it's the employer or the employee that is putting the money into the health insurance, all of that is eventually coming in some way out of wages, or potential wages. And so the driving and increasing costs of even private employer-based health insurance has been hurting Americans as well. The good news is that things have looked better for a number of years. Healthcare spending has been rising much more slowly. This is the rate at which healthcare spending is rising year to year, much more slowly in the last few years. You know, if you hate the Affordable Care Act, people will say, well, this is because the economy crashed and the economy's been growing slowly and everybody is seeing this worldwide. And there's legitimate claim to that. People who love the Affordable Care Act will try to argue that some of the cost containment growth and things that they baked into the cake of the Affordable Care Act are finally starting to take effect, and that's slowing spending. That doesn't seem quite as likely, given how few of those things have truly kicked in at this point. But regardless, there's been some good news. The fiscal outlook for healthcare spending in the future looks better because things have been growing more slowly. But we have so far to go. This is how much money on a parity level the United States and every other country in the OECD spends per person on healthcare. And you can see the United States all the way on the left there spends far more per person than any other country in the world. I want to show that to you in one more way. I've graphed here for you sort of wealth in GDP per capita on the x-axis and how much we spend on healthcare per person on the y-axis. And again, these are all in sort of parity numbers, so it's not, you know, dollars to francs. You can see that if I take the other 30 countries in the OECD, as a country gets wealthier, as their economy has more money, it is perfectly logical that they spend more on healthcare. And as countries grow wealthier, they spend, and in fact, it's a pretty tight relationship. And these are countries, by the way, it's not just us and them. Some of them have much more private systems than we do. Some of them only have private insurance. Some of them have tightly regulated markets. Some of them have even more. You know, Switzerland has likely even higher out-of-pocket costs than we do. It's not just socialism in the United States, but all of them form a reasonably tight relationship between how much money they have and how much they spend on healthcare, except the United States, which is that big bar up there, that big dot up there. The problem is not that we spend more on healthcare than almost any other country in the world. We should. We are very, very rich. The problem is that we spend so much more than you would expect given our wealth. The distance between that dot and that line is waste in some way. No one can figure out where it's going or why it's needed. The medicines don't work better when we spend more money on them. An appendectomy doesn't work better if we spend more money. There's a law of diminishing returns that we can keep spending money, but it's not going to do much good. In fact, you can see some of the countries all the way on the right there, I believe that's Luxembourg, you know, start dropping below the line because you could spend more money on healthcare, but it's not really providing much more. But we are way above. We are an anomaly in how much we spend given our wealth. So our access is suboptimal. Our costs are by far and away the highest in the world. You would imagine, therefore, that we could have an undisputed claim on quality. And on here, it's where things get a little bit tricky and we will differ. So there's lots of ways to measure quality. Sometimes it's measured on infrastructure, you know, that we have more stuff available. We have far fewer doctors than you might expect given our population, though. And in fact, we have a monstrous shortage of generalists. I just wrote about this in the New York Times, I think 2 weeks ago. But what you're looking at here is the percent of generalists in sort of the darker blue on the bottom versus specialists in the lighter up top. We are way, way understaffed in terms of generalists. This is why patients can't get in to see the doctor when they're sick. This is why it's hard to get care on nights, weekends, or holidays. The irony here, though, is that we don't have a glut of specialists. We have a rather average number of specialists if you look around the world. The problem is that we have so few generalists, it feels like we have too much specialists. We have too few physicians. Just We just do not have enough. Now, you can make an argument that we could train more, but of course, when it comes to medical graduates, we also rank among the lowest in the world. We are turning out far fewer graduates in doctors in terms of medicine per population than almost any other country we compare ourselves to. Now, you'll find economists will still argue that that's okay. We can replace this with mid-level practitioners. We can replace that with efficiencies. We actually have a real problem of geographic distribution. In some areas of the country, we have too many physicians. In other areas of the country, we don't have enough. But that's really hard to fix, especially in a free market where people are free to go wherever they like. Without passing major new incentives to try to incentivize doctors to move to places they don't want to live, it's very, very hard to fix this manpower problem. So when it comes to getting a doctor and deciding that we have a lot of infrastructure, there are a lot of holes. This is also deaths from cancer. This is mortality, and we can get into robust debates between whether we should use survival or mortality, but at the end of the day, I'd argue that mortality, the number of people dying from cancer, especially when we age adjusted, is a better metric. And what you're looking at here is that we are in the lower half of countries when it comes from deaths from cancer. We can cherry pick. Part of it is the problem is that's what we do, like with Canada. We're very good at breast cancer. We're very good at prostate cancer. We're pretty good at colon cancer. We're really terrible at lung cancer. And we're terrible at some other cancers. And when you stop cherry picking and just say, give me all the cancer, this is what it looks like. This is deaths from ischemic heart disease, where you can see again we rank, and I know it's hard to see, but I put the big red thing around there, in the bottom half. More people die from heart disease in this country than you might otherwise expect. I'll own that life expectancy is not a perfect metric, but again, this is a nice chart which is looking at, once again, healthcare spending on the x-axis and life expectancy on the y-axis, and every other country has a nice tight relationship but us. So we can just try to come up with reasons why, well, this one's not fair to us, and that's okay. It's not a perfect metric, but we're an anomaly again. Something is different about us than everybody else. And this is perhaps the best quality matrix that I can throw up there that gives everything in one. This is from a study in JAMA just a couple of years ago. And again, on the side there, on the left side, you're looking at the 31 countries probably in the OECD. And on the top are lots and lots of disease states. And the colors are what you really just need to see. And it's not important to see all the words. Green means, this is a chart looking at amenable years of mortality, amenable years of life lost. It's preventable mortality. It's people that died that likely shouldn't have died. We could do better. We know how to care for these diseases. We know what we are doing. It's a systems problem. For some reason, more people die than you would expect. Along the top there are diseases that are real. It's lung cancer, it's heart disease, it's breast cancer, it's stroke, it is HIV, it's cirrhosis, it's diabetes. It's very, very common things. Green means you're better than average. Yellow means you're average. And red means you're below average. The United States is green in only one thing, and that was stroke. We do well in preventing death from stroke. That was it. We are yellow in a couple of other things, but we are red in most of those. Because if we stop cherry picking, if we stop picking a country, a year, and we say holistically, how are we doing? Not as well as you would expect. And that's the problem. So we own that access is bad. Hopefully it's been improving, although even as I would argue, a lot of the other measures of access are not improving. Quality is below what we want, and we can quibble about whether it's as bad as perhaps I'm projecting it, but it's certainly hard to argue best in the world, given sort of the statistics that I've been able to show you. And our costs are absolutely sky high. It's not a rational system. It's not put together well. It's not functioning optimally. It could do better. I think we have the building blocks of a phenomenal system. Some of the highest trained doctors in the world. Some of the best hospitals. Our technology is top notch. We have access to the best pharmaceuticals. It's all there. It's just not put together well. And of course, with last week's election, everything is now thrown completely up in the air and no one knows what's going to happen. So the doom and gloom is usually, when I try to talk to it, is then followed by, here are some steps that we can take. And part of the problem is that it's very, very hard to predict at this point what's actually going to happen. No one knows. And anyone that tells you is going to be making it up as they go along. There's no way, let's be honest, the Affordable Care Act is going to stand as it is. There's just no way. Republicans now hold the House and the Senate and the White House. There's just no way that nothing is going to happen. Because of that, there are questions as to how things are going to proceed, but no one should be under the illusion that they're not going to proceed. One of the big X factors that still exists right now, of course, is the filibuster. It's the only thing standing in the way right now of full-bore repeal. The fact that the Democrats could stand in the Senate and say you must get to 60 in order to replace every piece of the Affordable Care Act is the only thing that prevents it just going away on day one. There's no way that the Democrats are going to vote for repeal. They may vote for a replace program, but there's no way that they're going to repeal. The Republicans just don't have 60 votes. It's just not there. And so the same problems that prevented Democrats from doing other things in the last couple of years when they had a majority but not a supermajority will now theoretically prevent the Republicans. Now, without eliminating, the filibuster, without getting rid of it, there are still things that the Republicans can do to try to change it. And that's what I will call option one. And that's to use what we call reconciliation. So most laws require half the House and half the Senate according to the Constitution. We all saw those cartoons when we were kids, and we understand that that's how it works. And then the president has to sign it. However, we also know that, as I just said, a filibuster has, in the last couple of years, certainly decades, been used to prevent that from actually happening if a minority really does want to block it. But there are some bills that can pass through another process called reconciliation. This was the process that was used to pass the amendment to the original Affordable Care Act back in 2010 after Ted Kennedy had died and he had been replaced by a Republican. And even though they only had 59 votes in the Senate, they were still, the Democrats, able to pass the law using reconciliation. A law that affects the budget and is going to affect the budget can be passed with only 150 votes. If the Senate parliamentarian rules, it will affect the budget. And so they can go, the Republicans can go to the Senate parliamentarian and say, we have come up with a repeal law that will affect the budget, and if the Senate parliamentarian agrees, then they only need 51 votes to pass it, and it is very likely they will get 51 votes. The closest thing that we have to understand how this might happen already did. It's H.R. 3672, which is the repeal bill that has already passed the Senate and the House in the past. It's the bill that they passed not too long ago. I think 2015 might have been the last time. But they knew that President Obama would veto it, and so they pushed it forward. So it repeals all the things that affect the budget. It will repeal all of the subsidies or the tax credits, which of course will reduce healthcare spending and will affect the budget. It will eliminate the individual mandate, which, because it is a tax, according to the Supreme Court, also affects the budget, and therefore it can be taken away. It will undo the Medicaid expansion, which of course also affects the budget. And so that can immediately go away. There's also a built-in 2-year delay, because the Republicans are not fools. The first is that this spares the midterm elections, because everybody remembers what happened in 2012 after the Affordable Care Act was passed in 2010 after the Affordable Care Act was placed. No one wants to make changes like this and then see a midterm election a year or two later. So this delays all the changes until after the midterm elections. It's pretty much the same thing that the Democrats did when they pushed off the exchanges and a lot of the stuff kicking in until 2014, even though the law was passed in 2010. It also gives time to figure out what to do in terms of replacing, because there is no consensus yet around replacing. But this is a pretty impactful bill. Don't mistake it. This would immediately upend and repeal significant portions of the Affordable Care Act. There's also things, though, it doesn't do, and these are just as important. It does not repeal the idea that family plans are still required to cover young adults up to age 26. That stays in place. That has nothing to do with the federal budget, because of course this is about just plans that are provided to individuals and they can buy them, and insurance companies, much like yours, and it's not something that necessarily has to do with the budget. There will still be requirements for no annual and no lifetime limits, because again, that affects you and that affects beneficiaries, but it does not affect the federal budget. So even though I just got rid of the subsidies, and even though I just got rid of the idea that I have to give people money to help buy it, you still have to provide coverage which has no limits whatsoever, and it does not do anything concerning the regulations about community ratings and guaranteed issue. So you still have to issue plans, they still have to have community ratings, they still can have no annual and no lifetime limits, and there will be no subsidies and no individual mandate. This is, of course, like death spiral. I mean, this is the death spiral of all death spirals. There's no functioning way that this will occur, but this is what would occur if that bill was just passed, 3672, all by itself. Therefore, Option 2 seems much more appealing to most people who work in the healthcare industry and also lots of other people. And that's the idea that we repeal and we replace. Because as I said, option 1 is devastating. Option 1 leads to 22 million people basically without insurance overnight. Medicaid expansion goes, well, 2 years later, if it's 2 years later, Medicaid expansion goes away, the exchanges are immediately crippled, all the sort of gains that happened go away. That will not be popular. It would also, of course, mean that there'd be significant repercussions, both for people in public office, not let alone the health and the American economy, and also how the healthcare system functions. So it is very likely, and a lot of people are pushing, that there should be some sort of replace plan there to sort of buffer this, to make sure that fixed. It is not that the Republicans do not have a number of plans that they have put forward. The problem is that a conservative idea for healthcare doesn't exist. There are a number of them. The problem is that there is no consensus. There is no plan that sort of has what anybody believes is enough to make it all the way through the House and the Senate and get signed. And I'm not even talking about the filibuster. I don't know that it can make it through the House. It is very difficult to get Republicans these days to agree on what they will do. Paul Ryan has a proposal. He's called it a better way. So at least that's one thing we can look at. He, instead of using subsidies, wants to come up with a sort of nationwide refundable tax credit to help people pay for health insurance premiums. So everybody gets this tax credit because it is a tax credit. It is not pegged to income. Therefore, even the poor would get it. Even if you pay no income taxes, you get it. That's the beauty of a tax credit. And so it is not a deduction, and it would theoretically help defray much of the cost. He has, the usual line of selling insurance across state lines. I'm sure you understand this as well as anyone. I put this in quotes, and I will admit up front, this one sort of drives me crazy because it sells, people love to use it, but the significant costs of setting up an insurance plan, I was talking to somebody before we began, are of course setting up the networks and making, the reason no one wants an Indiana plan is because the Indiana plan in Indiana covers the Indiana network. If you buy a Texas plan in Indiana, there are no Indiana doctors locally for you to see. I don't need to explain this to you, but it's like, why would I want a Texas plan that won't pay for a network of my Indiana doctors? If I get one, it's going to be bare bones. Plus, everybody knows that we will eventually get, theoretically, a market where one state will do away with regulations, a lot of the insurance companies over there, and offer very bare bone plans which won't really function very well, but could be sold across the country. But it will have no networks, it will have no deals, it will be very either costly or it just won't have the coverage that's necessary. This is a line. It's not the solution to sort of what we really need in terms of healthcare reform. Paul Ryan's plan does keep guaranteed issue. So he says that everyone has to be offered a plan, regardless of whether they have healthcare issues, we'll get it, but he does not keep the community ratings. So that means that, yes, you will have to offer a plan to someone who has a brain tumor or a child who's born with a brain tumor, but you don't have to do so. I imagine that plan will just cost $1 gazillion, and it will cost all of you an enormous amount of money to rate that plan individually. But it's an odd mix of it has to be given, but won't keep the ratings. And the important part, again, is that few others than Paul Ryan have weighed in. Now, I don't mean to be totally negative, and it's easy to stand up here and pick apart other people's plans. It is something that at least is there. And it is something that moves forward. But there are other plans out there that I think are even more thoughtful than this. American Enterprise Institute. One of my best friends runs AEPI, so you'll have to excuse me. So it always slips my tongue. But the American Enterprise Institute came out with a plan. Ovik Roy, who's here, has a plan transcending Obamacare, which is very well thought out as well. And doesn't have some of these twists, such as keeping guaranteed issue, but not community ratings. But there are other conservative ideas before we get to those as well. And I want to talk about 3 of them in detail because they're very popular. And these, again, I put in the camp of these make for nice lines when people are running for office, but they don't seem to work as well in practice. And those are tort reform, block granting Medicaid, where I'll put an asterisk because I think that could work well, and then raising the retirement age. And I want to spend just a few minutes on each of those. Tort reform is popular. And I have written a number of articles and done research on the malpractice system. And I'll be the first person to stand up here and say the malpractice system is broken. And it needs major reform. There are too many doctors who are sued on cases that really don't hold merit. There are too many patients who have actual malpractice occur and sort of can't get the compensation that is needed. There are needless lawsuits. They are handled poorly. The administrative costs of running the system are ridiculous. I absolutely 100% support the idea that tort reform or malpractice reform needs to occur. It is not, however, likely the reason for the high cost of the U.S. healthcare system. Tort reform, the idea and the theory behind it runs like this. We're going to cap damages. We're going to make it so that people can't make more than a certain amount of money in a lawsuit case. And because of that, lawyers won't want to bring the cases to trial. There'll be fewer cases. And because there are fewer cases and fewer payouts, insurance companies are going to see a reduction in their outlays. Therefore, they're going to bring down the cost of premiums because they'll see savings, and of course they will immediately transfer all of those savings not into profit, but into reduced premiums for the physicians who get their plans. And once those premiums see the reduced premiums, once the physicians see them, then they'll stop practicing defensive medicine. And that's going to bring down the high cost of healthcare in the United States. That somehow, if physicians feel safer, they are less likely to practice defensive medicine. Ironically enough, one of the best cases against this is right here. Because in 2003, you passed pretty comprehensive tort reform. You did it. You have caps on damages and a number of other things, and what you're looking at there is Texas in blue, and in red, the rest of the country with respect to Medicare spending, and costs of Medicare spending did not come tumbling down. If anything, they actually started accelerating beyond what people were seeing nationally. And so just passing tort reform doesn't bring it down. Well, there are reasons for this. You can do empirical research and see what would happen with tort reform, because there are areas of the country that have high malpractice risk of getting sued and low malpractice risk of getting sued. There are areas of the country with extremely high malpractice premiums and extremely low malpractice premiums. And a phenomenal paper in Health Affairs in 2010 pulled this out and said, let's look at places that have shifted from high to low risk, let's look at high risk versus low risk, and let's see what happens to physicians practicing. And it turns out that tort reform, which led to a 10% reduction in malpractice premiums, might translate into healthcare spending reduction of 0.1%. And a 10% reduction in premiums is pretty significant. I made a chart. If you look at the blue as healthcare spending, all healthcare spending, and we can debate about how much of healthcare spending is actually defensive medicine. Let's guess like $100, $150 billion, which is on the higher end. That yellow piece is what is defensive medicine. And the amount we might expect to change from tort reform, according to this research, is that tiny sliver that I pulled out there. That tiny little piece that you might not even be able to see in the back. The tort reform is necessary. Malpractice reform is necessary. It's a red herring. It is not the reason that healthcare costs so much in the United States. There's tons of other reasons. There have been phenomenal studies. Because of course, if you ask a doctor a simple question, hey, did you order this because you might get sued? A lot of them will say yes. If you say, what percentage of your reasoning was because you might get sued? Then it becomes like, I don't know, 1%? Because it's like there's lots of other reasons. Doctors often get tested not just because they're afraid of being sued, but because they're afraid of missing a diagnosis, or because they get paid more if they order the test. And financial drivers are important. 10-cent coupons exist for a reason. It's because they work. If a 10-cent coupon works, $100,000 reimbursements are definitely going to work. There's lots of reasons physicians order tests. And they're not doing it out of evil or malice, but it is not only because of that they might get sued. And even when we remove the risk of malpractice, it doesn't bring down healthcare spending that much. And so while this is an important thing we can talk about, malpractice reform, I do wish we'd pull it out of healthcare reform. In the same way that we sort of don't talk about NIH budgets in the same way we talk about healthcare reform. It's related, but it is different. Now, Medicaid block payments, I actually think are some of the low-hanging fruit of the next few years. I think they're very likely to occur because it is something that you can find that both liberals and conservatives can agree on in how we might reimburse Medicaid. The problem, of course, is in how you do it. Right now, Medicaid works, as all of you know, of course, by matched money. The idea is that whatever states spend, the federal government has to kick in a pretty big percentage of that. In fact, more than half for the most part. What Medicaid block plans do for the most part is remove a lot of the regulations and give states more flexibility. Instead, they say, we're going to give you this amount of money. It's almost more of a defined contribution and saying, we're giving you this much money, make it work. And then rely on states to use improvements in quality and improvements in efficiency to figure out how to do things better. I think that's fine in theory. I have no problem with that. The debate between and the arguments that occur in this is, of course, how much money they're going to give and how much that money dries up in the future. A lot of the plans in the past that have showed monstrous savings with Medicaid block granting, do so by significantly reducing how much they're going to spend in the future. In fact, the last time this was significantly pushed a couple of years ago, it was going to reduce spending in 2022 by about 35% and by half in 2030. Well, if you reduce the spending increases by that much, it looks great on paper, but of course, well, how do you do it? You know, Rhode Island was often held up as an example back in the day, but that really didn't come through. But again, this is back to the Iron Triangle. There's no magic in this. You can't magically, drastically reduce spending and think you're going to also somehow increase access and increase quality. With that drastic a spending cut, something has to give. Especially since, and again, this is probably not news to many of you, but it is often news to the country, where Medicaid money goes and who are the recipients. The green bars there are the number of people in each of these groups. The biggest group by far in Medicaid is children. The second biggest group is adults, but a significant amount of them are pregnant women. The elderly or the dual eligible are the smallest group there on the left, and the blind and disabled are the second group to the right. But the line is how much we spend on each of those groups. Way more money is spent on the blind and disabled, who are a much smaller group, than is spent on children, who are a monstrous group. And of course, the dual eligible, the elderly, cost way more than kids as well, even though they're a tiny fraction of the amount of children. So if you drastically reduce the spending that you're putting towards Medicaid, then they have to come from somewhere. It either has to come from cutting beneficiaries, it has to come from cutting payments, or it has to come from cutting benefits. There's no magic. And while I'm all for innovation and I'm all for trying to see it, part of what makes me a little squirrely sometimes about Medicaid block payments is I feel like it punts it to the states. It gives the federal government an out to say, it's not our fault, you figure it out. Now, for a lot of people, that's totally fine, because if you believe much more in a state-based run government, that makes total sense. Some states will do this well, some states will do this poorly, that's fine. My interest or my problems, and this will certainly, I'm sure, come up in the panel, is not in the idea of block payments themselves. I think some people have very thoughtful plans in how to get to block payments. The devil is in how this will be spun politically and how we reduce the paying payments in the future. Because if we reduce them very quickly, there are no easy answers. And sometimes we make the budgets look much better by thinking that there are easy answers by saying, well, this will get figured out in the back end. And the third is raising the retirement age, and I'm going to just spend one more minute. And lots of people think this one's a no-brainer. You know, they'll argue that people are living so much longer than they used to, and that it's going to save a ton of money. That is somewhat deceptive. What you're looking at here is life expectancy since 1950, pretty much until about now. But you're looking at it in two different ways. The blue on the bottom there is life expectancy at birth. Life expectancy at birth has grown dramatically since 1950. It's gone up a lot. And this is often what people will say when they say, look how much life expectancy was going up. When people passed Social Security, they had no idea people were going to live this long, and so therefore we need to increase the retirement age. But the red there is life expectancy at age 65. That means if you make it to 65, how much longer are you going to live? And you can see that since 1970, even in the 60s, life expectancy at age 65 has not gone up nearly as dramatically as life expectancy at birth. And these are the people, of course, that we have to pay for Social Security and Medicare. These are the people who make it to 65 and then we need to cover. So life expectancy hasn't gone up as much in terms of how much do we need to put out for Social Security and Medicare as many people think. Moreover, it has not gone up equally amongst people who are poor and who are rich. What you're looking at here is the top half of earners and the bottom half, of earners. And I pulled this out of the Social Security report, the numbers. The green line there is life expectancy at age 65 for earners of men in the bottom half of the bottom half. And the blue is in the top half. And what you should note is that almost all of the gains have been in the richer half of America. The poorer half of America has seen their life expectancy at age 65 from 1977 to today increase about a year. And if you follow the news, there's a lot of arguments that that's even been heading downwards or trickling off, that we're actually seeing life expectancy decrease for some of these groups as time has gone on. So therefore, it hasn't gone up quite as much as people think, and it hasn't gone up equally in the sense that the people who are going to benefit, who are going to be hurt by raising the retirement age are most likely going to be the poor half of America. This is not going to be something that affects everybody equally. The other thing is, how much can we save? And I grant you that this analysis, I kept it in the slides. This analysis was slightly old last week. It's now almost out of date because it, of course, holds that the Affordable Care Act would stay in place. But these were some numbers that were run the last time that we thought about raising the retirement age, and they said that if we raised it from like 65 to 67, or raise it whatever it would be, in 2014, the feds would save about $24 billion in Medicare. Because of course, if we raise the retirement age by 2 years, we save money in Medicare, feds don't have to pay for it. But that will punt some people back down and actually into Medicaid. So Medicaid spending goes up from the Fed's $9 billion. Subsidy spending, if the Affordable Care Act still existed, would have gone up $9 billion, because now we have to give those people subsidies to buy insurance in the exchanges, and since they're the oldest people, they're also the most expensive people. And the total savings, therefore, in the federal budget would be $5.7 billion. $5.7 billion is real money, but when we're talking about health care, it's not that much. Moreover, employers would have to pay an additional $4.5 billion because they'd have to now cover people who are 66, 67, who previously were going to be 65, 60, who were previously going to get Medicare. Insurance premiums for Medicare and private insurance would actually go up because as we drop old people into the insurance exchanges, they will raise the premiums because they are the sickest. And if we drop sick people into a risk pool, the price of everyone's insurance goes up a bit. State Medicaid spending goes up. Can't forget that. And then seniors would also have to pay more out of pocket because a lot of the plans that they would pick would require larger out-of-cost payments than they would if they had stayed in Medicare. And so at the end of the day, it turns out that the costs pretty much dwarf the savings. There are better ways to try to save money out of the federal budget. We can save $5.7 billion out of the federal budget in better ways than something that costs the rest of us twice as much. But anyway, there are still other ideas for how we might actually move forward and reform healthcare. One is to change the actuarial values of the plans offered. Right now, of course, the bronze, silver, gold, and platinum are like 60, 70, 80, 90%. There have been proposals. Overgroy's, I think, trade-sending Obamacare proposes 45, 55, 70, and 85. This would theoretically get more people to buy insurance because it would be cheaper. It would allow for a bit more flexibility in terms of people offering, and it may be that this is what people want, that they want the ability to buy plans which cover less, which require more out of pocket. Because it seems, again, I try to go with elections, it does not seem that the setup of the Affordable Care Act was enough to win this last election. There's also the idea that we could loosen some of the age bands. Right now, they're set at like 3 to 1, where the most you can charge an elderly person is 3 times that of a young person. That effectively screws young people because, and I put screw in quotes because it depends how you feel about it, because someday they will get to buy the older plans, but it does. It makes the health insurance of young people more expensive because this is what they have to do. Loosening the age bands to 5 to 1 to 6 to 1 would theoretically make insurance much cheaper for especially young people and especially people at the lower end. It might theoretically make insurance more expensive for people at the higher end, but again, these are ideas that are offered and then it is just a choice. But these are other ways in which that insurance could be adjusted and offered so that it might be more appealing and more people would want to purchase it. Another thing that could happen, of course, is to narrow essential benefits, to change what plans actually offer. And this one flows into option number 3, which is executive action, the other thing that can happen with respect to healthcare reform. Not everything requires Congress. The ACA is not as prescriptive as many people think. For example, birth control is not in the Affordable Care Act. It does not read in the law, you must cover birth control. What it does, it actually defers a lot of decisions to the Secretary of Health and Human Services. It says they get to decide sort of what is it. What has to be covered is a set of things that are considered essential to women's health. And the Secretary said birth control is part of that. That is why birth control is in there. A new Secretary of Health and Human Services could theoretically reverse that. Essential benefits in general are defined by HHS. And so that could be something that a Trump administration could change more easily than waiting for Congress. In the same way, what's a preventive service? Right now, it's deferred to sort of the USPSTF. It's deferred to other ways. There are workarounds and things that HHS can do in regulations in terms of trying to change what must be included in plans that would not require Congress and could be things that a Trump administration is. And it's important to remember that in some ways inaction can be as good as action. The Obama administration is actually fighting an appeal of King v. Burwell right now. Trump Justice Department could just stop. And if they did, that would theoretically end the subsidies to people in states where the feds run the exchange, which in other ways, as we talked about with full repeal, would cripple those exchanges. Most of those are actually federally run exchanges. Now, states could try to take action. There are workarounds to try to do that, but that would require states to want to do that. And given how no one knows what's going on with the Affordable Care Act, this could actually have significant thing. And this would cripple it. It wouldn't replace it. This would be very much just like doing outright repeal. But here's the thing. God, anyone who tells you they know what's going on right now is lying. It's important to recognize that these are all options. And these are the options that I can cover in 40 minutes in front of you today. We could spend the rest of this day and probably the rest of this week discussing alternatives. And no one can really predict what's going to happen. If for no other reason than to be quite honest, I do not know what is in President Trump's head. And that's not to say that I'm not even maligning him there. At the time, he said wildly different things about supporting single payer, about not supporting single payer, about thinking that universal health care is something that we absolutely should do, to thinking it is not necessarily something we should do, to arguing that it is the government's role to figure out a system that gets everyone who is poor and even perhaps more health care, to saying that is absolutely not what the government should be doing. I do not know. Moreover, there are Republicans in power who differ just as much on those. If you got all the Republicans in the House together, some of them feel like we should just scrap it all and just be out of this entirely. Others feel that there are ways to reform the healthcare system and try to come up with a better regulations, or a different way of doing tax credits, or a different way of doing Medicaid that would actually improve the system. But getting them to agree may be just as difficult as trying to figure out exactly what President Trump wants. These are interesting times, though, and it's going to be important, I think, for all kinds of groups to continue to try to be both in the president's ear, his administration's ear, as well as the ear of all their senators and congressmen, because clearly something is going to happen, and trying to come out of this in a way that tries to improve access, quality, and cost as best we can, while recognizing the inherent trade-offs, is going to be massively important. I don't know many people who loved the status quo ante, who think that, like, oh my God, it was paradise before. I hope I've shown you statistics and say it wasn't, and it's still not paradise. There's a lot we can still do to improve the healthcare system, to figure out if we'd rather have better access, rather bring down spending, rather improve quality, what we want to get, and what we're willing to give up to get there. Thank you so much for having me today. I'm happy to take questions. These are some of the many places you can follow. Get more thoughts from me. Thank you. And I don't know if you want to do questions, or if you want to move right into the panel. No questions. Very good.
Sir, if you were in charge, what are the three biggest things that you would do tomorrow, or over the next year, in terms of dealing with this issue?
So am I king? Like, can I do whatever I want?
You can do whatever you want. What are the 3 or 4 things you would do? Big things.
Okay, so if I had my dream, wow, I never get this question, but if I had my dream, I would completely decouple insurance from employment. That would be number one. I think it's ridiculous, and it's a trick of history, it is what it is, but we should have a system of insurance that has nothing to do with the job I have or that. So that would be number one. Number two would be to probably take away the system we have right now of a tax deduction, which only works for the employment, because if I get rid of that, I think probably a tax credit applied to all Americans to help them buy insurance would be a much better system. And the third thing I would do is, and I think it would surprise some people who think they disagree with me, is I would love to see a system that did not rely so heavily on so many different systems like Medicaid and Medicare and private, an individual private market and a private market. Like, I was reasonably entranced with Wyden Bennett back in the day. The idea that we would just get to sort of one big system where we'd find a way to subsidize people at the low end of the socioeconomic spectrum to get into the same insurance system that everybody else had, but to try to have a system that sort of encompassed everybody from birth even to death, I'd be fine with, that sort of helped, that was fair and sort of helped people. But having just said that, I've made myself now I will never be able to be elected to public office, and I have literally 0% chance idea that would happen. But I do fall in I think that it is a right of government, or a job of government, to help regulate this system and make sure that it is functional and come up with the boundaries and make sure that people at the low end, even to the middle, because healthcare has gotten so expensive, to help them be able to afford it. But I would have no problem with it being radically reshaped from what it is today. I think there's a real opportunity right now The question is whether we will move in that direction or whether we'll just sort of flip to the opposite.
Great presentation.
Thank you.
You talked about, being from Indiana. I'll give you a short question maybe without going into great details. Can you elaborate about the Governor Pence's work in Health Indiana 2.0 programs, that he was able to do it with the ACA grants, and now we're hearing that there are some rumors around that Health Indiana program will be the blueprint of the replacements with all the elements about that.
As a Hoosier, that's just mind-boggling to me. Okay, so yeah, this is another one where if you'd asked me this question a week ago, I might have laughed. But Indiana's an interesting state. And I've lived there for like 13 and a half years, and I love Indiana. But I believe in my heart, and there's no way to prove this, that the reason that we got sort of Health Indiana 2.0 was because being a red state, that our healthcare industry, our insurance industry, the pharmaceutical industries, we have a very large medical device industry there, all got together and were like, you must figure out a way to get this money to us, that we can't not get the Medicaid expansion. And since that aligned with what Democrats also wanted in the state, there was a real push to find a way to get the Medicaid expansion and yet have it be palatable to a very red legislature and obviously a very conservative governor. The ways around that were to have co-pays, to have people required to pay a minimum in premiums. But if you get down in the details, there were a lot of ways still that those premiums and those co-pays were going to be covered either by charities or by other things in the state, or they'd find ways to waive them. And they were minimal in terms of dollars. No one should be under the illusion that the amount they were going to bring in premiums or co-pays would make any dent in the budget for Medicaid. But they definitely theoretically can make a dent in people's willingness to pay. And so they probably reduced the number of people that signed up for plans. They probably did make some changes, as I showed you in Access, in terms of like, will I fill that prescription or not? But they probably served people well when they got hospitalized and when they actually needed serious care. And they served as a mechanism by which we could find a palatable way for the state to accept the Medicaid expansion in the way that worked. This is again where it's like I throw up my hands, and I also think, to be honest with you, it costs more than straight up Medicaid, and it probably reimbursed a bit better than straight up Medicaid. But I've always been of the mind of like, I get that there are trade-offs in healthcare. If we improve access by increasing spending, I can live with that. And so if the way to get this done was to say, we want better access, this will cost us more money, doctors will get reimbursed a bit more, okay. I know people who are very budget conscious who don't like that because they'd rather spend less money, or they think there are other ways to do it. And there probably are more efficient ways to do it. And I think there's some administrative costs to running all those power plans and all the health savings accounts that are being run, because this is a population also that is very poor. And there's an argument to be made and some data that show that they haven't always been very good at knowing what's going into those accounts and what's coming out. And that is fine. That is part of what happens. But if you ask me today if I would take Healthy Indiana 2.0 and that would assure the Medicaid expansion across the country, I'd say okay, because I would take something to nothing. And I think that finding a way to get, an option, even if it's not ideal, to try to improve access, and it might cost more money and might improve quality, okay. There are trade-offs that are going to happen, and that I think. I don't know that I would be totally sure that that's what's going to happen, though, in the same way that I don't know about any of this. Mike Pence has never been, I think, a guy that's been running on his healthcare bona fides. Indiana did produce a Medicaid expansion, but I don't know that was. Maybe I'm wrong about that. I just, I admit I'm not a tea leaf drinker or tea leaf reader of Mike Pence, but I think that probably there are many stronger heads in Congress and perhaps even in the Trump administration who will be pushing harder for the direction that healthcare reform is going to go.
We have to pause there, but Dr. Carroll has graciously agreed to sit in on our next panel, so if you do have questions for him, he will be on our next panel, which will start in about 5 minutes.
Thank you again.